Let's now spend a few minutes on seizure disorders. We're going to go pretty fast here because we're going to look at this specifically as it relates to pregnancy. Here's our case. A 25-year-old prima gravida is 19 weeks gestation, almost halfway through the pregnancy. She has a 10-year history of generalized seizures, poorly controlled, requiring hydantoin and valproic acid. Whenever she needs two medications, you know that it's got to be poorly controlled because you would preferentially just use one anticonvulsant. Now, valproic acid is problematic because of its association with neural tube defects. And in fact, a triple marker screen result shows an elevated maternal serum AFP. That makes us suspicious. Could she have a fetus with a spina bifida because of her valproic acid? The effect of pregnancy on seizures in most cases is unchanged. And those patients who have an increase in seizures were probably more difficult to control to begin with. What is the effect of pregnancy on medication levels? The levels will fall. And for a number of reasons. One is hemodilution, because you have an increase in plasma volume. Two, you have an increase in renal plasma flow, and so increased clearance of these medications. So we will again check the dosage and the therapeutic level probably every trimester, and we will need to probably increase the dose of our anticonvulsants. If she is well controlled, pregnancy complications should be minimal. If she's not controlled well, it could do very poorly. That's as far as a mother is concerned. In terms of the fetus and the neonate, there is clearly an increase in malformations. One anticonvulsant, you double the rate of anomalies. Two anticonvulsants, you triple the rate. And many of the anticonvulsants are FDA category D in pregnancy. Cerebral palsy, mental retardation. And that is just one of the limitations of the treatment. As you see here, many of the common anticonvulsants are category D. And yet, if there is no other way of maintaining seizure control, you've got to do what you got to do. Now, we would prefer to use something like lamotrigine, lamictal, category C, and some of the newer medications to see if we can minimize the effect on the fetus. There is now increasing discussion about the AED syndrome, anti-epileptic drug syndrome. And when we look at these different syndromes, a phenytoin syndrome, a phenobarbital syndrome, they may very well be mediated by a common epoxide metabolite. And that's what is responsible for the teratogenic effects. In pregnancy with epilepsy, we want to give folate supplementation because there is decreased folate absorption with anticonvulsants. We like to start this prior to conception to prevent malformations. Offer anomaly screening, the expanded AFP, the triple marker screen, between 15 to 20 weeks, and we want to take a look with ultrasound at 18 to 20 weeks to see if there are any major malformations. If possible, get her down to only one medication, monotherapy rather than multiple agents, and we'll monitor the medication level so we can maintain a therapeutic dose. And that's the end of seizure disorders in pregnancy.